Hi there. Thank you for joining us today for the presentation by the Nova Scotia Provincial Wound Management Program. This presentation has been developed specifically for continuing care assistants, but is also vital information for any of our frontline healthcare workers. So welcome and let's get started. So the objectives for today's presentation: the healthcare provider will gain knowledge and understanding of skin function, a basic skin inspection. What exactly is a pressure injury? What are the stages of pressure injuries? How do they happen? And what can we do to prevent pressure injuries? So the CCA role is crucial to the overall health of the clients they provide care for. Therefore, it is important for CCAs to understand the functions of the skin, how pressure injuries happen, and ways to prevent them. Although the CCA is not responsible to stage a pressure injury, it is a very important aspect of their role that they recognize and report when skin is at risk of developing a pressure injury. CCAs are often the frontline workers who are in the best position to observe for daily changes in the skin, to identify increased risk for those who have a higher risk of developing a wound, and to note poor and nutritional intake of the residents they care for. The skin is the largest and most visible organ in the body, and it comprises up to 15 to 20% of the total body weight. The skin has many functions. The first, of course, is protection. So the epidermis, which is that outer layer of skin, acts as a barrier to protect underlying tissue from mechanical injury, dehydration, and the effects of harmful substances. It also prevents many disease-causing organisms from entering the body, so it really is the first line of defense for our body. Thermoregulation, so temperature. Capillaries within the dermis, which is that layer just beneath the epidermis, they have the ability to dilate and constrict in response to heat and cold. So this process results in an increased or a decreased blood flow to the skin, and this can lead to a greater or lesser amount of body heat being lost. Elimination of waste products. So of course, the body excretes waste through our sweat glands. So this is another very important function of the skin. Synthesis of vitamin D. Vitamin D is synthesized by the skin in the presence of the ultraviolet radiation from the sun. So of course, we want to be careful with sun exposure, but we actually need a little bit of that sun exposure to synthesize the vitamin D. So that is another important function of the skin. Sensation. Nerve endings that enter through the dermis provide skin sensations such as pain, cold, heat, touch, and pressure. And of course, communication. The skin serves as an organ of communication. So we think about this when, if we have, say, for example, a client that we're caring for and this individual is nonverbal, we often look for those facial signs, whether it's a facial grimace, smiling, pouting. We rely on this form of communication to let us know exactly what that individual is feeling. The skin has three main layers. So we have the epidermis, so that outer layer, we have the dermis, which is beneath, and then further beneath the dermis is the subcutaneous layer. So the epidermis is your outermost layer, and that's non-vascular in nature. The dermis, on the other hand, it lies just beneath the epidermis, and these two layers connect to each other by these tiny little projections. They're like wave-like projections, and they keep these layers together. However, as we age, these layers start to thin out, and as they thin out, they're more susceptible to being torn away from each other. And this is exactly what happens when we have a skin tear. So when these layers separate due to a force that's applied against them, this is called a skin tear. And this is an image of this is a type 1 skin tear. We call it a type 1 skin tear because, as you can see, the wound bed is completely covered. The skin flap is able to be pulled back and carefully pulled back and reapproximated to cover that entire wound bed. And we have the subcutaneous layer. So this is known as the fat layer beneath the dermis. The subcutaneous layer plays a critical role in pressure redistribution. So we may ask ourselves, who is more at risk of a pressure injury? Would it be somebody who is very thin and they have very small amount of subcutaneous fat, or would it be somebody who has an excess of subcutaneous fat? Well, the answer to this question is actually both, and especially if they become bed-bound or chair-bound. The very thin individual lacks that subcutaneous tissue, so this means that they have less padding over those bony prominences. And when you have the other extreme, when you have somebody who has an excess of subcutaneous tissue, this actually increases the pressure between the skin and the surface beneath that skin. We also know that when we have excess skin tissue, it tends to be more poorly perfused, which can lead to slow wound healing. So as the skin ages, we talked about how the layers thin out and we're more susceptible to skin breakdown and skin tears. We also have a decrease in melanocyte function. So therefore, we see that our hair starts to turn gray and we start to develop these little age spots all over. Our blood vessels become more fragile, so our skin tends to bruise more easily. And our sebaceous glands, so these sweat glands, the sebaceous glands tend to produce less oil, which leads to dry skin. And then we talked earlier about those sweat glands and the important role that they provide with skin function. So what exactly is a pressure injury? It's defined as there's localized damage to the skin and underlying soft tissue. It is usually over a bony prominence or under a medical device. So the injury can present as intact skin, so no openings at all, or there can be openings and it can be a painful ulcer. The injury occurs as a result of intense and/or prolonged pressure or pressure in combination with shear. And the tolerance of the soft tissue for pressure and shear may be affected by such things as microclimates. So what is the moisture situation that you're dealing with? Nutritional status of the individual, perfusion, how is their blood supply? Any comorbidities that they may have, so other disease processes which may be occurring with the individual, and the overall condition of the soft tissue. There's many risk factors for pressure injuries, such as limited mobility, prolonged exposure to friction, especially shear and moisture, decreased nutritional status, aging skin, being underweight or overweight, contracture of the limbs, history of a previous pressure injury. We know that those individuals who have experienced a pressure injury in the past are more susceptible to developing another pressure injury. And those individuals who experience decreased sensations. So these individuals, they don't have the ability to feel that sense of pain or pressure. Limitations in mobility is another factor. So mobility is considered to be limited when there's a decreased ability for an individual to reposition themselves independently, whether that be in a bed or a chair. It's really important for those individuals who have limitations in mobility that we address this appropriately, ensure that we have the appropriate interventions in place. And we'll talk a little bit more about that. So remember, the best practice guidelines recommend that we should reposition every 2 hours for bed-bound individuals and hourly for chair-bound individuals. Even if your client is on a pressure redistribution surface, a positioning schedule is still required. So let's talk about exposure to friction and shear. So what is friction? Friction is the reaction that happens when skin is rubbed against another surface. And for an example, you can think of, say, an elbow against a bed sheet. So when that elbow is constantly rubbing against, that's creating some friction. And most of us have experienced that. And an example of what shear can be, so I want you to think of this example. If we have somebody who is sitting up in a bed in that high Fowler's or semi-Fowler's position, and they're sliding down in the bed, so the bones of the pelvis are moving in one direction, but the skin is actually moving in another direction, and this is creating the force of shear. And it's quite destructive to the tissues. There's some ways that we can reduce friction and shear. So it's important to keep the skin dry. Lift when positioning, avoid dragging your client across the beds, and ensure that you have the appropriate equipment to assist you with repositioning in bed. Low friction linens that will significantly reduce that amount of friction and shear that's happening, and keeping the head of bed less than 30 degrees when able. This is an important intervention, and I know sometimes it's difficult to encourage somebody to lay back that far in the bed, because sometimes they want to be watching TV or whatever. But when they are able, it's really important to encourage them to lay back, because what happens there is you're decreasing the pressure, especially on those vulnerable areas. Risk assessments. It's important that clients have risk assessments done using a validated risk assessment tool. And I understand that the CCAs are not responsible to complete this risk assessment tool, but they are responsible to ensure that the interventions that are implemented as a result of the risk assessment tool are carried out. And those interventions should be able to be located in the individual's care plan. A basic skin inspection. So what are we looking for when we want to do an assessment of the skin? We're looking at things such as temperature, color, moisture, turgor, and integrity. So with temperature, the skin is normally pretty warm to touch, and warmer than normal could be a sign of inflammation. And on the other end, cooler than normal could be a sign of poor circulation. So it's really important to compare from one side to the other, and it's important to know what is the normal for that individual. And when there's variations outside of what you recognize to be normal for that individual, that's important to report. Color. So of course, there's many different colors and pigmentations, and skin can vary from very light pigment to, of course, very dark pigment. So culturally component skin assessment is basically an awareness of the differences across the skin pigmentation. And basically, it's important that somebody is able to recognize what is the normal skin for that individual. What is the normal skin color of that individual? And are there any variations from what is the normal? Moisture. So when we're thinking about moisture, we're looking for signs of moisture, or we're looking for lack of moisture. So for this image here on the left-hand side, we see this individual is experiencing severely dry skin. So this skin is actually in need of a moisturizer. We're looking for signs of moisture-associated skin damage. So if we can see the picture on the bottom here, we notice that this individual has what looks like an incontinence-associated dermatitis. So we're looking for signs of moisture. We know that excess moisture puts the skin at an increased risk. So moisture is just not due to incontinence. It can be due to perspiration if we have a client who perspires heavily. There's another type that if somebody has a wound and there's a lot of exudate or drainage from that wound, they can get moisture-associated skin damage around the wound. And of course, those, if they have an ostomy, they can get damage around moisture damage around the ostomy. So the image on the very top here we can see is this individual has some pitting edema. So it's important to note if there's edema as well and ensure to report that. Turgor is another one of our assessment items, and tented skin normally returns to its original state pretty quickly. And when we're testing for turgor, we're basically doing a basic little skin test here. We pinch the skin up and we let it go, and we see that the skin returns back to the normal position. However, with dehydration, we often notice that the skin tends to stay tented for a longer period of time. And one of the natural occurrences that with aging is that also skin can stay tented for a little bit longer than normal. Integrity. We're looking at the overall condition of the skin. Is there any open areas that we are aware of? Are there any areas that we're concerned about pressure? Are we noticing reddened areas, moist areas, any areas that we see that is different for the normal for that individual? This is where we report and document any noted changes. Don't forget to inspect the creases. We really can't emphasize this enough. Our body, we have so many little creases and nooks and crannies, and bacteria loves to just get into these areas. So they love moisture and they love heat, so that's where bacteria tend to go. So look at behind the ears, under the breasts, the armpits, the abdominal folds, in the groins, behind the knees, and between the fingers and the toes. It's really important to inspect all of these creases. So we know that pressure related to a skin injury can develop in a very relatively short period of time. It can happen in minutes to hours. And this varies from person to person depending on their overall clinical position. We do know that higher pressure loads require less time to develop a pressure injury, but we also know, as we stated earlier, that lower pressure loads for a longer period of time are also just as susceptible to developing a pressure injury. So some questions that you can ask yourself to help determine, are you dealing with a pressure injury or not? Ask, can you confirm the presence or history of pressure or a combination of pressure and shear? That's one question you can ask. Another question is the area of injury over a bony prominence or under a medical device? And if you can answer yes to those questions, then chances are you're dealing the injury as a pressure injury. So there's multiple stages of pressure injuries, and the list that I'm going to go through today is the National Pressure Injury Advisory Panel, which is the NPIAP, and there's multiple stages here: 1, 2, 3, 4, unstageable, and deep tissue injury. We also will have a quick peek at oral mucosa injury, as well as a medical injury, pressure injury related to a medical device. So the way I'm going to present this is I'm going to compare to some fruit and vegetables here. And this is an article that I'm referencing, and this is where I'm getting my information from for the comparison. So it's teaching the fruits of pressure ulcer staging. I know that we no longer call them pressure ulcers. We now call them pressure injuries. The authors of this article are located here. You can see them on your screen. So stage 1. Stage 1 pressure injury is intact skin with localized area of non-blanchable erythema. So what do we mean by non-blanchable erythema? So there's an area of redness, and when we put some pressure on that area of redness and then we remove the pressure, the area does not turn white. It stays red. So when we apply that pressure, it does not have any impact on what we're seeing there. So that means it's non-blanchable. There can be a change in the firmness of the skin, so we're going to see this red to pinkish color, and it doesn't, as I said, it doesn't change when the pressure is removed. So what are we going to think about to think of a stage 1 pressure injury? We're going to think tomato. So a tomato is red. The skin is intact on that tomato, but when we press on the tomato stays red. It does not change white. It stays red. It's non-blanchable. So a red tomato is a red tomato. Red tomato does not blanch. It's a stage 1 pressure injury. And this is just an example of how we can test for blanching. So stage 2, with stage 2 pressure injuries, we have a partial thickness loss of the skin with exposed dermis. So we have some pink granulated tissue in the wound bed. There's no slough in there, and it can be a serum-filled blister that can be either intact or can be broken. So if we have a look at these two images here, we can see that it basically is superficial. It looks like something has just come along and swiped off that top layer of skin there. So what are we going to think about for that? We're going to think about a potato. Like a vegetable peeler has kind of been taken right across the top of that potato, and it's taken off that very, very first layer. So there's a partial thickness loss to the potato skin. So stage 2, vegetable peeler swiped across that potato. And these are some examples of stage 2 pressure injury. So remember, we said it can be an intact or a non-intact blister. And these two images that we have on either side of the blister are really good examples. And it does look like a peeler has just been scraped across there. The important thing about stage 2 is that we don't want to confuse a stage 2 pressure injury with a couple of other injuries, because these are not pressure injuries. Moisture-associated skin damage is not a pressure injury. We know moisture-associated skin is more at risk to develop a pressure injury. And medical adhesive-related skin injury, so MARSI. These two should not be confused with a stage 2 pressure injury. Again, go back to those questions and ask yourself. So what is moisture-associated skin damage? There's 4 different types of moisture-associated skin damage. So we have incontinence-associated dermatitis. We also have intertrigonous dermatitis. We have peri-wound moisture-associated damage, and we have peristomal moisture-associated damage. So damage related to incontinence, so that is when the skin has contact with urine or stool. Intertrigonous dermatitis, we see this sometimes in the skin fold, so the bacteria gets in there and the skin gets really red and irritated. Peri-wound, so as I said earlier, if we have a wound that has some exudate, that surrounding skin can get really moist and damaged. And the same for those with the ostomies. The peristomal skin can become damaged. Out of all 4 of these types, incontinence-associated dermatitis, which you may often see abbreviated as IAD, is the most common. And as I said, that's from exposure to urine or stool. And MARSI, medical adhesive-related skin injury. So this is an occurrence in which there's redness and other manifestations of skin abnormalities. And this abnormality persists for 30 minutes or more after you remove the adhesive. So right here, we can see a skin reaction to a medical adhesive. The medical adhesive was removed, so that tape, whether it be a wound dressing or just tape, it was removed, and we see that there's a reaction there. So that's, they are the 2 main types that we don't want them to be confused with a stage 2 pressure injury. So moving on now to a stage 3 pressure injury. With a stage 3 pressure injury, we have full thickness loss of the skin, fat tissue is visible, granulation tissue is in the wound bed. What we do not see, so I emphasize we do not see with a stage 3, is we don't see underlying structures. So we don't see bone, tendon, or muscle. We don't see these underlying structures. The wound bed may contain some slough, and the slough or this dead tissue does not prevent us from actually viewing or completely seeing the wound bed. So that's a stage 3. So let's think, what are we going to compare this to? We're going to compare this to an apple with a bite taken from it. So we see that the skin of the apple is gone, and then we see that the bite is deep down into the apple, but it's not down so far that it's down to the core of the apple. So it's a full thickness tissue loss, stage 3. And then we go to stage 4. So with stage 4, there is full thickness tissue loss, and there's exposed or directly palpable. There's bone, muscle, ligament or cartilage, tendons visible in this wound. Slough or really dark adherent eschar may be visible. Rolled edges, or what we call epibole, may be present. There may be undermining or tunneling within this wound. And again, it's caused by pressure or pressure in combination with shear. So what are we going to compare the stage 4 to? We're going to compare this to that apple or the peach that is right down to the core. Okay, so if we're thinking peach, the peach pit is actually visible. And this actually represents those underlying structures. So whether that's your bone, your ligaments, your tendons. So this wound is deep enough that it goes down to those underlying structures. Unstageable wounds. So when we have an unstageable pressure injury, it's unstageable because we cannot see the wound bed. There is full thickness skin and tissue loss. but the extent of the actual damage cannot be determined because it's not visible. In the image on the right-hand side here, we see this black eschar present on this heel, and we have no idea how deep this wound is. We do know that, especially with the heel, that bone doesn't lie very far beneath the skin in the heels. So once again, we can't see under it, so we have no idea how to stage this. With the image on the right, we can see a little bit of red tissue there, but for the most part, we can't really see the wound bed. It's obscured, or it's kind of, our vision is blocked by this yellow and brown kind of sloughy material that we have in the wound. So again, if we cannot see it, we cannot stage it. So these are both examples of unstageable pressure injuries. So for the unstageable, think of the rotten fruit. So with the rotten fruit, we can see that there's necrotic tissue there on the top. So it's dead tissue, it's rotten, but we do not know how far this goes down. We don't know if it goes down as far as those underlying structures or not. So therefore, we can't stage it until we can see it. Deep tissue pressure injury. So this can be either intact or non-intact skin. There's a localized area of persistent, non-blanchable, and it can be deep, deep red, or it can be this purple color, maroon color, and there can be some separation of the edges from this discoloration here. And then it can reveal a dark wound bed or even a blood-filled blister. So we're going to think this stage, we're going to think of the eggplant. So the skin covering the eggplant is actually intact here, but the purple coloring represents that the tissue has been damaged. So there's been some ischemia happening here. So when we have increased pressure, so whether it's those sit bones or the coccyx, wherever it is, when those bony prominences are under a lot of pressure, the capillaries actually start to bleed, and the circulation is impaired there. So that's why we see this purple discoloration. So deep tissue injury, purple, we're going to think eggplant. So we talked and we mentioned that there's another tool that we would like to discuss here, the medical device related pressure injury. So this results from the use of devices that are designed and applied for a specific reason, a diagnostic reason. So whether that's a Foley catheter or a nasogastric tube, we're more familiar with hearing about these medical device related pressure injuries, considering the fact that we're in a pandemic and we know a lot of healthcare workers have been wearing a significant amount of PPE, so they may experience a pressure injury at the bridge of the nose from the mask or behind the ears. This type of injury is staged using the pressure injury staging system. But we just note that it is related to a medical device. Now, with a mucosal membrane pressure injury found on the mucosal membrane is not staged using the pressure injury staging system. And the reason it is not is because the tissue of the mucosa, so your mucosal tissue, it differs in anatomy from the skin. So because of this difference in the anatomy, it cannot be staged the same way. So we do not stage these with the pressure injury staging model. So this would actually be documented as a mucosal membrane pressure injury on the lower lip in the photo here, related to a medical device. So, go back there. So once again, we often place different types of tubes, whatever it is, like oxygen tubing, endotracheal tubes, nasogastric tubes, urinary catheters, fecal containment systems. They're just some examples of the medical devices that we use that can cause a mucosal membrane pressure injury. So when we are looking at pressure injury prevention, there's a little acronym that you can think of, SSKIN, so SKIN with a double S at the beginning. And this bundle stands for, the first S is skin inspection, surface, K for keep the individual moving, I for incontinence, and N for nutrition. And we'll go through each of these. We talked about the importance of skin inspection earlier, so it's really important to assess the skin for any signs of breakdown Look for those reddened areas. Do they blanch? Is there evidence of moisture-associated skin damage? Again, the skin inspection is very important. We have multiple opportunities to assess the skin throughout the day when we're assisting our clients with toileting, bathing, personal care, incontinence care are just a few examples of the opportunities that we can inspect the skin. So the second S is for surface. So reducing the intensity of pressure with the use of support surfaces and reducing the duration of the pressure, and we do this by position changes. These are both critical interventions in pressure injury prevention. Offloading the heels. This is another important aspect. A lot of us are familiar with these these offloading heel boots. It's really important if you are using these boots that they are applied correctly. If you're unsure of how to apply them correctly, because the heel has to be floating, and that's so important. So if you're unsure, reach out to your colleagues, ask your supervisor, just reach out to your interdisciplinary team members and ask and get some advice, and they will certainly assist to show you how to make sure that you are applying these boots appropriately. And if you're not using boots, some people don't like the boots and maybe they would prefer to use a pillow. Using a pillow is okay, but you have to be cautious here because the heels do have to be floated, and it's important that the pillow supports the length of the lower leg there. You don't want to put any extra pressure on the Achilles tendons, and we also want to make sure that we're not compressing behind the knee there. So again, ask for some help. Be interested in the appropriate ways to reposition your clients. Avoid shearing. We talked about this. Avoid dragging the skin across the bed. Use your shear reduction lift sheets. Lift, don't drag. Keep the individual moving. This is so important. If they're able to walk, assist them with that. And if they're able to walk independently, encourage them to do so. Reposition at least every 2 hours, or as noted in the care plan, and avoid pressure injuries. So when your client is in bed and you're positioning them, if you notice that there is an area of pressure, just say, for example, that area is on the coccyx. When you're positioning that resident or that client, you want to make sure that you're not positioning on the area of pressure. So use your wedges, your pillows, your devices to appropriately position that individual. Encourage the individual to change position frequently when they're up in the chair. And if they're not able to do that independently, it's really important that you assist them to do that at least hourly for sure. Some individuals are fortunate enough that they may have a wheelchair like we see up in the top photo here. This image shows a tilt wheelchair, and when we tilt that chair back and we have it almost to the degree where the individual is looking up at the ceiling, that really is it's a great tool to reduce that pressure. And of course, follow the care plan for specific positioning instructions. Less than 30 degrees. So what do we mean by this? Keep the head of the bed less than 30 degrees when able. We talked about this in a couple of slides ago. But if you're sitting in a seated position right now with your feet flat on the floor, I want you to take your 2 hands, palms up. Place each hand under your sit bones. So just place them under your buttocks there and you'll feel the pressure on your sit bones. If your feet are firmly planted on the floor, just keep in the angle that they're currently in, just lift the foot up off of the floor and you can feel the difference in the pressure on those ischial tuberosities, or otherwise known as the sit bones. So position and how you're positioned has a significant amount on the pressure. So pressure on the buttocks in the sitting position can be as high as 300 milligrams of mercury over those sit bones. So we also know that low pressure for a long time can be just as destructive as high pressure for a short time. So again, positioning, we can't emphasize the importance of this enough. If you're not sure the best way to position a client, when in doubt, shout it out. Ask for help. You've got lots of members of your team that can assist you. We know we have to offload the pressure, that this is critical in the prevention of pressure injuries. We often say in wound care, we could put gold on a wound, but if we don't go to the source, the cause of that wound, which is the pressure, we're never going to progress towards healing. So our number one intervention is to redistribute and offload that pressure. This slide simply shows us some examples of the high pressure points when individuals are in different positions. So we know that this high Fowler's position is the greatest position to cause that shearing force. It puts a lot of pressure on the ischial tuberosities, those sit bones, the sacrum, elbows, shoulder blades, and the back of the head. And in comparison, when somebody is in a sideline position, the pressure points then become the ankle, so the outer aspect of the ankle, the side that's against the bed, the knees, the hips, the shoulders, the ears. So, and so on for, as you can see with the other two images there. So positioning is so important in offloading those pressure points. So the I in that SKIN acronym, SSKIN, the I stands for incontinence. So protecting the skin from incontinence and other moisture by ensuring that we're keeping the skin dry. So that means that we have to ensure we're giving timely incontinence care, that we're using the appropriate size. If somebody is in an incontinence product, that we're using the appropriate size incontinence product for them. We never ever double pad. That certainly is going to add moisture and add heat and put the skin more at risk. Is your individual, do they perspire a lot? If somebody is a very sweaty person, the skin is going to be moist. And what about bed linens? Is there a lot of bulky bed linens on the bed? If someone especially has a specialty support surface mattress, and we have all these bulky linens, we're taking away that action of that mattress. So it's really important to not have a lot of bulky linens on the bed. It also will trap the heat and trap the moisture. So when we're talking about incontinence care, it's really important that we are cleansing the skin with a nice pH balanced skin cleanser. The normal pH of the skin is 5.5. We want to avoid any harsh soaps. We want to make sure that we're cleaning those creases well and that we're patting the skin dry, that we're not vigorously rubbing the skin dry. Do not rub or massage reddened areas. So when we have a reddened area, we know that this area has already experienced some tissue damage. So remember when we're going back to the stage 1 pressure injury, so there is damage to the skin, even though that the skin is intact, that persistent redness tells us that we have a stage 1 pressure injury. The last thing that we want to do is to go in there and start vigorously rubbing and adding more pressure and causing more damage to those areas. So what we want to do there is we want to reposition and offload, not rub hard on those areas. And the final N stands for nutrition. So we know how much of an important role nutrition plays in the prevention and treatment of pressure injuries. We need these nutrients and the fluid, the hydration. We need this to promote growth and maintenance and repair of body tissues. It's fantastic when individuals get these beautiful meals and lots of drinks are offered throughout the day. But if these drinks are offered, but they're not consumed, then they're not serving the purpose. Same, for example, we have an image here of a delicious protein shake. If the protein shake is sitting on the bedside table or on the in the home, if it's sitting on the kitchen table and it's not being consumed, then there's no point in it. So it's really important to note if an individual is taking in, if they're consuming the appropriate nutrition and hydration. So what can we do as healthcare providers to optimize this nutrition? Well, we know CCAs are often the ones who are helping our clients with their eating and their drinking. We can encourage consumption of a balanced diet based on the individual requirements and based on their specific likes. Document the food and fluid intake, as well as the intake of any nutritional substances, and Of course, we say this over and over again. Report to the supervisor. If you've noticed a change in the individual that you're providing care for, and you notice that they're not eating or drinking well, it's really important to report that. Interventions can be put into place. And if you really want to stimulate someone's appetite, a great way to do that is to really ensure that they're receiving good oral hygiene or denture care. We know that the CCA role is critical to the optimal skin health for the clients that you care for. So we're going to look at a very basic case study here, and we're going to call this gentleman Bob. So Bob is 84 years old, and he lives in a residential care facility. He spends most of his day up in the wheelchair. His medical history is, there's nothing too significant there, but the staff do notice that because of his stroke and his right-sided weakness, that when he is up in the chair, he tends to lean to the side quite a bit. Bob is also a diabetic. His medication's not too bad. We're not too alarmed by anything that we see there. The staff reported that they noticed an area of non-blanchable redness on his right buttock, and it is near those sit bones on the right side. So that sit bone area is really red. They report this, and they believe it's a stage 1 pressure injury. The area did not blanch when they applied pressure to it. So sure enough, it was assessed to be a stage 1, and interventions were put in place accordingly. So OT, the occupational therapist, was involved. The dietitian was involved. The nursing team was involved. CCAs were involved. Once everybody was involved and they looked at the case, they decided, okay, we're going to get Bob a Roho mattress for his bed and a Roho cushion for his chair. They initiated a strict positioning schedule, and this was being adhered to by the CCA staff. The dietitian, suggested high protein drinks, and these were being offered and consumed by Bob. They also ordered, the occupational therapist recommended a tilt wheelchair. It was ordered, but unfortunately there's no expected date of delivery as of yet. So 2 weeks later, we noticed that the wound has progressed to a stage 2. So the staff couldn't understand, why did this happen? It was picked up early. It was a stage 1. The skin was intact. All of the appropriate interventions were put in place and were being carried out. So why did this wound continue to deteriorate? Well, the team members, all the interdisciplinary team members gathered again, and they did another reassessment. They realized they are doing all of the appropriate interventions. They're all being carried out accordingly. They know that the cause of this injury is pressure. So the next step was to again go in and reassess the surfaces. So the bed Roho mattress was deemed to be in fine condition. It was inflated properly. There was no issues with that at all. And when they examined the Roho cushion that was on the wheelchair, they noticed that there was low air. So this was an issue. The OT assistant corrected the issue, so she ensured that the Roho cushion was inflated to the appropriate setting. And what happened here is the facility actually developed a new policy and required for the CCA staffs to do, or any member of the staff, not just CCAs, it could be your LPN, your RN, your OT, your PT, your assistant, to perform these. Someone had to perform this daily hand check of the Roho cushions. So with the proper offloading, the resident then went on to heal. So with this case, sorry, my slides went backwards a little bit. This is an example of a Roho cushion that was placed on Bob's wheelchair. So for the hand check, how this is done is basically the hand is kind of slid between the cushion and the individual when they're sitting up in the chair. Then the leg is lifted slightly, and you get a feel for that lowest bony prominence there. And then the leg is lowered back down. So the results, if you can slightly move your fingertips, the cushion is at the proper cushion inflation setting, and no further adjustment is needed. If you can easily move your fingertips and there's too much air between the lowest bony prominence and the seat surface, but if you cannot move your fingertips at all, there's too little air there. And that means that that bony prominence is actually sitting right down, and the pressure is not offloaded at all. So you have to report if adjustments are needed so that cushion can be inflated appropriately. And that's exactly what happened to Bob. This last slide here is just a list of my references that were used throughout the presentation. And what I really want to say here is thank you to all of the CCAs, those frontline workers who do an amazing job every day. You are such an important and integral part of the team. So thank you very much. And I'm going to open it up to questions right now. If anybody is interested in receiving a certificate for their attendance, I've placed the link here at healthassociation.ns.ca on the screen here. You can simply send us an email and we'll get that to you. And if you're interested in any more information, especially on support services or best practice guidelines, I really encourage you to visit the Health Association in Nova Scotia website. So HANS, Health Association Nova Scotia, and there is a link there for the wound program. So once again, thank you everybody for joining us today, and I hope you enjoyed the presentation. Take care.